Good evening, everyone, and thank you so much for joining us tonight on this program for our webinar. I'll introduce myself, a little about me. I'm Dr. Lamia Gabal. I am a proud alum of the UC San Diego School of Medicine, class of 1995, and I am also a member of the Medical Alumni Association Board of Directors, and it is my pleasure to welcome you all here tonight. I'm a board certified urologist. I have a subspecialty board certification in female pelvic medicine and reconstructive surgery. I'm also the founder of Prestige Medical Group in Tustin, California, where I practice alongside my dedicated team. And hard to believe, I've been in practice there now for 25 years. And this evening's program will offer a deeper look at UC San Diego Health's mobile health program, highlighting the need that it addresses, the impact that it's making across San Diego County, and the ways that our alumni and community can engage and support this important work. Our webinar is part of a broader journey to health equity effort at UC San Diego Health and focused on expanding access, strengthening community partnerships, and advancing equitable care. And we're especially excited to have alumni joining us tonight from all three of our health professional schools, the School of Medicine, the SCAGS, the School of Pharmacy and Pharmaceutical Sciences, and the Herbert Wertheim School of Public Health and Human Longevity Science, along with other alums, faculty, staff, and community members. And tonight, it's my pleasure to introduce our presenter, Dr. Crystal Cené. I've seen her present before, and she does a wonderful job with all of this. And she serves as Chief Administrative Officer and Associate Chief Medical Officer for Health Equity at UC San Diego Health. And she's a nationally recognized leader in health equity research and practice. In her role, she's focused on creating an equitable, diverse, and inclusive environment for patients, staff, faculty, trainees, and students. She's also a professor of medicine at the UC San Diego School of Medicine in the Division of General Internal Medicine and a professor of public health at the Herbert Wertheim School of Public Health and Human Longevity Science. So, Dr. Cené, I'll turn it over to you. And following Dr. Cené's presentation, we will have a Q&A. So if you do have any questions during the presentation, please submit your questions using the Q&A feature on your screen. Thank you.
Okay. Well, thank you so much, Dr. Gabal. I really appreciate the opportunity to be here and to get to share part of the evening with you all. I don't ever take it for granted when people come to any presentation or talk that I do, and I certainly don't take it for granted when you choose to come at 5:30 in the evening, because I know there are many other things and places that people could be spending their time. So going to talk a little bit today about health equity more broadly, some of the work that my department is doing, but center on the mobile health program, as you've already heard. So you can go to the next slide. So I think you've heard a little bit about kind of who I am professionally. And, I'm, as Dr. Gabal said, I'm an internal medicine physician. I have a master's in public health, and it's focused primarily, my training was in epidemiology, cardiovascular epidemiology is where I've centered a lot of my research. I'm a health services researcher, so I've trained as in research and have done a lot of work, and that's how I spent my time up until taking this position is pretty much 80%, 70 to 80% research and 20% clinical as a primary care outpatient doctor, and trained as an implementation scientist as well. So you can go to the next slide. And you've heard a little bit about that professionally, but really what I want to tell you is just kind of how I became how I came to the work that I do now, because I think it's really important to help understand the work that I do for the health system and what I'm really passionate about. So these are some pictures. So I was raised in a very small rural coastal fishing community in North Carolina by my grandparents, who are in the picture at the top left, in the house that you see at the bottom of the screen. And my town was really what has now become known as healthcare deserts, right? There were no doctor's offices, there was no hospital. The nearest offices or hospital were probably a 30 to 45-minute drive away. And so what that meant was your family and the community, whether, your broader community, we probably had less than 2,000 people in our town, in your church or what other social groups you're a part of. Those became the trusted messengers for all health related information. I don't recall ever going to a pediatrician or a dentist or any of those things when I was younger. And my grandfather was the unofficial mayor of our town. He was a civic and a community leader, very much beloved. And from him, I really got my love for working in and with communities. And it actually sort of introduced me in a way to this notion of public health, which I had no knowledge of what that meant, didn't even know it was a thing, and really didn't know it was a thing until the end of college. So at the end of my senior year in college, I was fortunate to get a travel scholarship that allowed me to spend 3 months in Ghana, West Africa. And so while I was there, I lived and worked with a public health nurse. And I worked with her on a community-based research project, which was really focused on addressing the high maternal mortality and morbidity among women who lived in remote villages. So that we worked with, traditional birth attendants, kind of a variant of a doula, maybe now we might call them. And I was really spending a lot of time just out in the community and helping. And that really sort of introduced me to this field of public health and really my love for that and working in community and with community messengers, if you will, or partners really grew from there. So at the picture at the top right, this is a much younger and clearly braver me, and at the Masai Mara in front of taking this picture in front of a rhinoceros. I don't think I was even realized the danger I was probably in, but needless to say, I survived, so I'm glad. And then this picture at the bottom was me as an intern at Yale University. So I did my primary care internal medicine residency there, and I was doing an ED shift. And really, that's when I first sort of, well, one, it cemented the fact that I made the right choice of going into sort of primary care. But what I gained from that experience was that I knew then that I wanted to sort of answer clinical experiences that I was having with my patients in clinic or in the hospital. I wanted to answer those questions with hypothesis-driven research. And again, I hadn't had any research training, didn't know really what that was, so decided to do a research fellowship after residency. And so I did a 3-year research fellowship at Johns Hopkins, and that's where I also did my MPH. So really for the past 20 years, I've been conducting research that seeks to understand and address sort of social contextual influences on health and health disparities, particularly around cardiovascular risk, and to develop interventions to address those disparities and improve population health. So that's really the lens through which I see the work that I do, both as a researcher, but also now in my role in the health system. Next slide. So part of my sort of personal mission, if I had to boil this down in terms of how I think about my role here, I feel really privileged to sit kind of on both sides, if you will, in the health system, on as a member of the executive team. And the health system obviously is where we center our patient care and our clinical services, but also to sit in health sciences, both in the School of Medicine and public health, which is where we center our teaching and our research and our learning environment. And my goal is really to connect these two systems, which are obviously tightly interwoven, but sometimes feel worlds apart, to be able to translate what we know from research and evidence and best practices into the clinical environment to do the things that we know work, and to learn from them, all for the purposes of improving the outcomes for patients and the communities that we serve, and eliminating the health inequities that we see and that are so entrenched in much of our care, just in general. Next slide. So this, I like to always kind of zoom out and talk about some data that I think is really some of the most striking data. And that's, we all know that where you live shouldn't determine how long you live, but the reality is that it does. There are significant variations in life expectancy across San Diego County subregions, similar to what we see in other regions and areas of the country. But I want to highlight here that, it's also life expectancy is tied to also income. And so when we look at, if we compare, for example, Lemon Grove or National City, and we compare that with North County, San Diego, we see the big difference in median household income. But what we also see is about a 10-year difference in life expectancy. Next slide. So when if we put this kind of into context of two of our hospitals, Hillcrest and La Jolla, our sites that are in those locations are geographically close, right? If you want to drive, it's a 19-20 minute drive. If you want to bike, it's, you can get there in less than an hour and a half, yet they're 10 years apart in life expectancy. And I happen to think that that is unacceptable. And so these are the type of data that really motivate the work that I do in health equity, and on why I think we really have to center on trying to make some changes to close these gaps. Next slide. This data I typically show in all of my presentations because I think that it elevates the point that, when we think of the things that contribute to the health of a population, healthcare, what we do in our clinics and hospital every day, is only a small part of that. That work is important, make no mistake, but it's only a small part. It's about 15% of the overall things that contribute to health status. Whereas if we look at social circumstances, environmental influences, that accounts for about 45% of what contributes to health. And similarly, health behavior patterns is about 40%. So what this says when I see data like this is it means that we, for those of us who are kind of in the clinical care space, we have to move beyond our brick and mortar. We have to move beyond our four walls if our goal is to advance health. And I know for all the folks who are from public health and who are thinking more broadly, you know that this is true. You know that we have to work in partnership with others to really advance the health of a population, because we can optimize, and we should optimize, the care that we provide and give our patients the best outcomes that are possible. But even if we do that, we still have to do more if we're wanting to improve the health at the population level. Next slide. And that's because we all know that there are many social and structural drivers of health. And this slide kind of lists all of them. Many of these are all things right? They're, economics and education, and the food environment is really important, and the community that you live in, and access to technology and things that promote health are really important. And healthcare access is one of those social drivers of health. So that is really important, that we provide access and we extend and expand access to people as one of the drivers, but it's not the only thing. If we really, again, want to improve health, we have to think about how can we get as many of our tentacles out into these other things, these other areas. How can we partner, because we can't do it alone? How can we partner with others to make changes in these social and structural drivers? So you can move to the next slide. When we think about designing for equity, one of the things that I say in our work over in the health system is that health equity is really our true north. And health equity, when you think about it, the aspirational goal, it implies that everyone has the fair and just opportunity to be as healthy as possible. I could spend a lot of time unpacking each of those words. Well, what does fair mean? And what does just mean? Well, what is, not everybody's going to be healthy. We know that, but it's really, I think the most important word in there is opportunity. And that's really what we're trying to do is create opportunity spaces so that people can take advantage of all the health promoting resources that they can and minimize the health damaging resources so that they can have the opportunity to be as healthy as possible. Disparities in health and in health outcomes and in the key determinants of health, some of those things that I just showed on the previous slide, those are the metrics that we use to gauge our progress at advancing health equity. Those are one of the metrics that we use, certainly within the healthcare system. Are we having disparities in our clinical outcomes and our processes and some of these drivers of health? So if you look on the next slide, this is just giving you a sense of, for my department, kind of what are the strategic priority areas that our work really falls in. So this department was started when I was recruited here about 3.5 years ago. And so obviously it makes sense that we focus a lot on infrastructure building, trying to make sure that we're laying down structures and we're affecting systems that allow our efforts to be successful and sustainable. And then we focus a lot on healthcare equity. We're just now really starting. We've been building the foundation for a few years, getting our data and infrastructure into place and getting governance structures, which is part of the infrastructure building, into place to make sure that we are positioned to close disparity gaps in our patient care and outcomes. The next level is really work around community health and well-being. And really, that's thinking about what are those non-medical drivers of health in the community that we can affect change on so that we can help people stay healthy. So that's really our community-focused work. And then the last area here is around dissemination and collaborative partnerships. As I said, when you look at that data slide that I showed, we can't do this alone. The health system is never going to, in and of itself, help people at a population level be healthy. We have to think about partnering with others. And so we really think a lot about how can we build partnerships, but also how can we disseminate what we know? And this is me bringing my sort of researcher hat and me as an academician. We are really invested in publishing the work that we do and really putting things out into the environment to help people understand how do you put health equity and health equity research into practice in a care delivery setting. So on the next slide, I'm not going to go into all these, but you take those big strategic priority areas, and what I've highlighted here is just some of the things, this certainly isn't all of them, just some of the things that we're doing in each of these areas. But again, I won't go into the detail of all of those, and I think afterwards I can share with you some of our sort of annual reports or we put out a quarterly newsletter. I'd love for any of you who are interested in getting that, just let me know and I'll send out our latest copy of that. But just so you have a sense of what we're doing and how we might more effectively work together and partner on some of this. But also in the middle, you see kind of what our vision is. We envision a future where every patient and community has the opportunity to be healthy and to thrive, free from social and structural barriers. And we pursue this vision through education and capacity building to address health and healthcare inequities, engaging in multi-sectoral partnerships to promote health, and implementation and dissemination of best practices. So I talked about that a little bit on the previous slide. So now I'm going to transition on the next slide into talking about our mobile health program. So really the mission of this program is to reduce those access-related barriers by bringing healthcare services, research, and educational opportunities to individuals and communities that need them most. And some of the services that we're currently offering and we are just like, I feel like it's phase 0.5. I don't even know if it's phase 1, but I guess I'd say phase 1 if I had to land on a whole number. We're very early in this work. We spent 2 years. I was able to get $1 million to launch this program to buy our two mobile clinics from through congressional appropriation. So that money came through HRSA. And so we spent a lot of time kind of developing and planning and all of that. And then we just kind of launched in the fall. So right now we're really more in the screening phase of services. So we're doing point of care hemoglobin A1C testing, which tests for diabetes. We check blood pressures. Our mammography unit is obviously screening for breast cancer. We're helping connect people to community resources and providing health education. So we're in this very early phase. We're not doing any sort of acute care medicine. We're not doing full scope primary care right now, or specialty care, but those are all things that, we would love to be able to move into in our next phase. You can go to the next slide. And I'm going to talk a little bit just about our two clinics. And I have lots of pictures in this deck, so hopefully it'll become a little bit more real for you, kind of what this looks like, and you might get a sense of the work that we do through the images. But this is our mobile mammography clinic. So it's a 30-foot coach, it's custom fabricated, it's equipped with a GE Healthcare Pristine mammography system. So it's a 3D mammogram system. It was designed for women by women. It's low dose and really great image quality. I would encourage any of you who are breast cancer, who are engaged in the screening, come get your mammogram here. We have patients who tell us all the time that the machine, it's much less painful than the machines in our fixed sites. Although I'm encouraging mammograms, so don't ignore because of pain, because generally they're not too painful. But this one, we certainly have gotten a lot of feedback that it's much more comfortable. And the tech that we have in this clinic is very seasoned, is lovely, and people really like her and think that she does a great job. So we started, we have our mammogram parked at our Rancho, both of our clinics actually, but this clinic is parked at Rancho Bernardo at our Vita Zone clinic. And so when we're not out in the community, it's parked there so people can schedule and just come and get their mammogram here. And what I mentioned that because what you'll see is that the volume, if you look at that graph on the right, kind of the number of patients that we're screening. So again, not all of this reflects us out in the community, but some of it is just UCSD patients who are choosing to come there versus other times we're doing work in partnership with other community organizations. But our volume has steadily it's been increasing as we build partnerships. So overall, we've screened over 1,500 total patients between UCSD and at our community events. We've done 9 total events, including health fairs, and work with community partners. We're constantly every day signing building new partnerships and establishing MOUs or memorandum of agreement or understanding. So with San Diego American Indian Health Center, places like that, we're really trying to partner with a lot of the FQHCs who themselves may not have great access to mammograms. Many people are waiting a long time, much longer than they should, to be able to get a scan. So it's really meeting a need because there is, at the time that we started, and I think it's still true today, that there are no other mobile mammograms in the region. And so we get a lot of interest in this, and we're developing right now have established some partnerships with Neighborhood Health and Optum and Calviva. So Calviva serves all of the school employees. So we're going to be doing some stuff at school so that the teachers and school personnel will have access to mammograms. We'll just go to their site and do it. And then San Ysidro. So working with some of our local health partners as well. Next slide. So this is our general health clinic. So this is a 36-foot coach. It's equipped with 2 exam rooms. It has a bathroom, medical grade temperature control refrigerator, a section for lab draws. It's ADA compliant and both of our units actually include wheelchair lifts for patient access. Obviously, as the health equity team, it was really important for us to make sure that these clinics were accessible for those who have differing abilities and mobility. And so when we look at this clinic, we've done screenings on about 388 people so far. We had a large spike in October. What you see is we did an event with Population Health Services Organization, which is one of the UCSD Pop Health team. So we did a large vaccination event where people could come out and get their flu shot during flu season. So a lot of our employees were vaccinated then at that clinic. And we've done 17 total events with community partners. We have a partnership with the Haitian Bridge Alliance, so we go there every month and serve the Haitian community. We've done stuff with El Dorado Community Center. We go we went to the MLK Junior Health Festival. And then we just did an event last week for Love Your Heart Week over at our East Campus Medical Center site. And that was a really successful event. We had a lot of our team members, our employees come out to that event. And so again, even with this unit, it's the same thing. We're constantly looking for new partners and trying to build new partners. And I will say one of the challenges that we face is that many of the FQHCs or federally qualified health centers, the larger ones especially, have their own mobile clinics. So with the general health unit, it's a little bit more, you need a little bit more creativity to think about where is the unmet need. And so that's some of the work that we're doing too, is what are the services that we can provide and how do we better meet the needs that are out in the community. Next slide. One of the things, again, as an academic that and faculty in two of our schools, I'm really excited about is we created a mobile health elective that's actually going on now. So it's first offered this winter elective, and we decided to limit it to 20 students. 20 MS1s, and we had more than that. So we ended up having a wait list, but we were able to get a couple of people off the wait list. So it's a combination of didactic lectures as well as service events. So we have our students are actually the ones who are doing the testing and checking blood pressure, checking diabetes, doing all of the different roles. We have multiple roles at each of our events. So whether it's interpretation, interpreting for people who may not speak, English, or doing our registration or helping with health education. So, and we have attendings who are supervising them. So it's been really great. And these are the topics that were addressed in our elective for the first 4 weeks, and kind of an intro to mobile health care and what's the landscape of mobile health and what are the different models and how are all the ways that you could use this and how do you think about return on investment? And I'll have a slide on that later. And then we did some work around the preventative health screenings that they were going to be offering. Because again, these were first year medical students. So many of them are just starting to learn this. And, they're learning, well, what's a normal A1C and what's pre-diabetes and what's diabetes? So we did that, and we did, very interactive and some case-based work to help them understand how do you counsel people? How do you talk about things in a way that's literacy sensitive and educational, and really thinking about culture and how do you explain stuff. And so that was a really good session. We had a great session on wound care and thinking about how do you care for folks who are unhoused, and particularly the wounds related to that. And so the picture at the top right is from that session, and the students were super engaged, and it was just a great session with two of our nurses who do essentially, they kind of go out and do street medicine on their own. It's not part of their jobs, but they're just committed and have been doing that for a long time. And so they did a lot of work. And then we had one of our leaders in our wound care on a wound care team also present at that talk. And then we did one around health education and literacy. Because again, when you're working with people in the community, it's really important that our students understand how to translate kind of the medical speak, if you will. How do you explain that to people who may not know how to read, who may not understand, who may be coming from another country and just aren't familiar with all of the jargon? So we had a great session on literacy from one of our nurse educators in our patient education department. Next slide. And so just so this isn't a thing that we came up with. Mobile health is a national movement. And there are data from the mobile health map. This is, it's a partnership between Harvard and a couple other entities. And this is where if you want to understand anything around the landscape with mobile health, they actually capture all of that data. You register with them so they know all of the, you can obviously choose not to, but the mobile health, most mobile health programs are registered with them. It's free to register essentially. And so they pull and get a lot of data that helps us to really understand what is the benefit of mobile health. And so from their analyses, I mean, there's over $1 billion return, and a $19 to one. So every $1 you invest in mobile health, it returns $19 to that program. In terms of ED visits avoided, that's one of the main things that you want to look for when you have a mobile health program. So one of the ways that you do that is when people come to get mobile health services, especially when you're using a model that's more like primary care or an urgent care where you're providing some clinical service, beyond just the screenings, you'll ask them, where would you have gone if you had not come here today? And one of the options is the ED. And so when they look at this, this is avoiding over 47,000 emergency department visits. That's huge, especially because in ED visit, nobody wants to be in the emergency department. It's already super congested and compacted, and nobody wants to be in the hospital. And so ED avoidance is a really important metric when you're looking at mobile health programs, and also life years saved. Obviously, nobody can argue with mortality. And so this is a really also an important metric when you're thinking about mobile health. And then on the next slide, what we've done is, because one of the things that this mobile health map, the platform that one of the benefits of the platform is you can input your own specific data, your estimates or your actual data when you have that, and see what is the potential impact of your program. And so we did this a while back, just based on if we were to have 3,000 visits, kind of what would that return look like for us? So for us, it's a $10 to one return on investment. We could avoid 660 ED visits and 275 life years saved. So again, there is benefit, and there's a financial benefit for mobile health programs, in addition to the fact that these programs are designed to meet people where they are, both literally and figuratively. And I mean, that is really helpful for people. Most people want to be able to get access to care in the communities where they live, with people who are, providing that care in a way that's culturally sensitive, that's trauma informed. And so those are things that we really prioritize, is making sure that we are providing care in a way that makes people feel respected and included and welcomed. So next slide. So as I said, we're sort of in phase one. And here are just some things that we are working on, or that kind of are in many different stages of development. So obviously, we're still trying to build infrastructure because we want to be able to scale and spread, and we want transparency and accountability. And so obviously, we're, hiring clinical staff. We're in the process now of hiring a clinical manager for our mobile health program, because you can imagine it's sort of like it is like starting a brick and mortar clinic, except that clinic is on wheels, with all the things that can happen when you have a clinic on wheels, where you have two staff that are there, as opposed to a clinic where you got nurses and LPNs and doctors and security on site and all of these things. So it's a lot more. There are a lot of things that have to be built in the infrastructure. And you see, San Diego hasn't done this before, not in the health system. I mean, we obviously have the iMobile and the senior iMobile through Shiley, and they function a little bit, differently, providing great care and services. But like, for example, for us, we have to set up an Epic department and a billing department so that we can think about, how do we get the data to be able to track our outcomes? So all of that stuff has to be, created. And those are things that we're working on. Solidifying our operations and really doing some more strategic planning to think about our next phase, and when do we move into that next phase, and who are the new partners that we need to engage, and balancing that between what the community needs and what we're able to provide. Because, for example, in a mobile clinic, let's just say our general mobile clinic with 2 exam rooms and a small space to collect labs, it's not like a regular fixed site clinic or brick and mortar clinic. There are a lot of things that we can do, but there are a lot of things that we can't do. And some of the needs, and we did a lot of work, many thanks to Blanca Melendres and the Center for Community Health and some other partners who, when we were planning this, when I first started, we had a group that really helped do a lot of early planning. And Blanca's team and ACTRI, Center for Community Health, they facilitated these focus groups so that we could get a lot of input from community partners around what are the needs. And for example, one of the main needs that came up was for dental care. Well, that's not something that we can provide with this mobile clinic right now, right? Thankfully, our student run free clinic, has dentistry at some of their sites. But there are mobile clinics that are specifically set up to do only dental. They have dental chairs and equipment. So that's a need, an example of a need that is really felt in the community, but that we're not able to address. So again, we try to do the things that we can and balance what does community need with what we're able to provide. I've already alluded to, we're always thinking about new partnerships, and I'd love if you all know of folks and people who might want to partner with us, let me know. And one of the things that we're looking at specifically related to the mammography mobile clinic is looking for funding solutions for uninsured patients. So right now, we are, because mammography is so heavily regulated and you have to give results back within a certain time frame, and you got to give them to the primary care doctor, and you also have to give them to the patient. You can imagine if somebody doesn't have a primary care doctor, well, that becomes challenging, and we could get in trouble from a regulatory standpoint. So again, we have to partner. But what we also have encountered is that there are many people who come for mammograms who are walk-ins at the community, like at the monthly health fair that we do. And we can't do their mammogram because they're uninsured. And many of you may say, well, don't they, isn't everybody insured? Don't they have Medi-Cal? Well, there are some reasons why people are ineligible or they choose not to get Medi-Cal. The state does have a program, Every Woman Counts, that provides free cervical and breast cancer screening for people who don't have insurance, but you have to get enrolled in that program. And UCSD is not an enrolling provider. They can get their mammogram with us, but we don't, because it's a whole bunch of regulatory stuff around that. But we're looking for solutions to that, because we don't want to turn anybody away. We do not like, so we're building actually a partnership with San Ysidro, because they also go to this same health fair, to see if we having people who are coming who are uninsured, if they can enroll them in Every Woman Counts, and then we can then we can do their scan and pick up. We're also looking to establish a donor pool for if people want to give money to be able to cover the uninsured patients, so that we can give them a mammogram for free, so that cost is not a barrier. We don't want cost to be a barrier. And so that's one of the things we're working on, where it's with our our revenue cycle team, because obviously UCSD has kind of a charity care policy and a charity care process, and we have to make sure that we're not impacting that in any way. But again, our commitment, what we really want to make sure is that we don't have to turn anybody away. We don't want cost to be a barrier. Okay, so next slide. How can you get involved? So there are 3 big ways. You can donate, you can volunteer, and you can advocate. And I just want to go on the next slide. I just have a couple more slides here. This is just an example of kind of what if you decided to give. And when you get these slides, we'll send out these slides. This is a hyperlink actually to our pool, what your money would go towards. We want to be super transparent and super responsive and responsible. So for example, if you gave $500, that would support a half day of supplies and fuel. That we are always going through a lot of supplies when we are at different events. And obviously the mobile unit takes a lot of fuel. If you wanted to give, $5,000, that would power a whole week of our screening services. So we just have some different ways. We want to be flexible and make it possible that everybody can contribute to advancing health equity through providing access via our mobile clinics. And every dollar you give actually generates $10 in community health value. So we think that's a pretty good benefit, and hopefully you all will agree. And then on the next slide, just as important is volunteering and advocating. So sharing your expertise. If any of you are interested in precepting our students, we have medical students who volunteer. We have PA students. We've understood that there are some challenges with the pharmacy students coming. We really desperately want pharmacy students also to be volunteers because they provide, we all bring a different lens and a unique perspective and expertise in healthcare, and we have to work together. So as we're expanding our services and talking to people about medications and thinking about literacy, I think the pharmacists are great in thinking about literacy and communicating. We have some excellent pharmacy team members here. So precepting is one way, or donating your time. If you are good at strategic planning or something, help us think about the next phase. Engage in those conversations. Obviously, opening doors for us, again, helping us connect with other partners. You can host an event. We've had somebody who's offered, like, hey, I can host an event because I have a lot of friends who are donors or who are philanthropists. Let's host something. Let's show them the unit. So that would be great if you could do that. And then advocating, spreading the word, sharing this work with others. I think this is how I got on to do this webinar with you today, is by doing it at the Medical Alumni Association. So spread the word about what we're doing, not only our mobile program, but our broader health equity work. And championing their work. It's always been important, but it's even more important with a lot of the changes that are happening, that we really use our voices as healthcare professionals, with policymakers, with the general public, and just being an ambassador and representing our commitment to expanding health for all populations. And so I think that's it. On the next slide, you see my contact information. And then the last few slides, we'll just show them quickly because they're just some pictures just to show you from our different events. The event, our Love Your Heart, you'll see all the red and the balloons in the back. That was from Love Your Heart. Some of these are from mammography. This one at the bottom left is from our Haitian Bridge Alliance. The Haitian Bridge Alliance is a great partner for us because they provide a lot of basic needs. They have a warehouse that people come there every, month to get basic needs and supplies met. And so our team collects donations for them. In addition to us going to do the screenings, we partner with them on, really helping to try to get supplies to support the Haitian refugees and immigrants who receive other services there. And on the next slide, you'll just see just some more pictures. We do a huddle in the top right. You'll see we always start our events with a huddle, everybody introducing themselves, what role they're playing in the clinic, just kind of centering ourselves on the work that we're trying to do, but more importantly on why we're doing the work. Here you see some insides of the clinic. This is one of the exam rooms. And then in the middle at the bottom, you see kind of the A1C machines. We usually try to run at least 2 to 3 A1C machines, and we have 2 rooms to be able to screen folks. And then on the last slide, again, just more pictures. At the top left, there's a couple of our medical students who work at our events, and at the bottom you can see our registration table, and we have a health education table, usually separate, on the other side. And then we have lots of volunteers. We have nurses who come and volunteer with us. We had some nurses from Azusa Pacific University who volunteered with us last week. And we really, again, we want this to be as multidisciplinary as possible because it takes all of us and the unique skills that we bring to advance health. So I think that's it. I am happy to answer questions.
Wow, thank you so much, Dr. Cené, for this informative and inspiring presentation, and honestly, for all of the amazing and good work that you are doing to help our community and its members. So thank you so much. Really incredible. We'll now open the floor to questions. I want you, please submit your questions in the Q&A box if you haven't already. We will do our best to address as many as possible this weekend, but if we're unable to get to all of them due to the time, we want to be respectful of everyone's evenings. We'll follow up individually afterward with some additional information. So, my first question that we have received here is kind of a multi-part question, and it is: How do you define the build? How do you define the building of structure around health equity? What kind of systems are set up to ensure that structure? And then, has that been affected by available funding for healthcare and for research?
Yeah, thank you for that question. So, when I think about building the structure for health equity, it's a couple things. So, one is having people to do the work, right? So it's building our team. I also think it's governance, right? So we created a health equity council that we're coming up on our 2-year anniversary, and that includes leaders from, we have representatives from all three schools. Thankfully, we have representatives from the health system, clinical and operational leaders. So it's an infrastructure to know this work is happening, to guide the work groups that are being established, to guide the work. These are all, a lot of the people who are on the call are leaders within each of those in their respective departments or areas so that they make sure they're amplifying and elevating and ensuring that we have what we need to be able to do this work. Another part of infrastructure is getting the data infrastructure into place, right? And so we created a data and health equity data and analytics steering committee, you know, 3 years ago when I started, and we've been really done a lot of work with, how we're collecting data, and some of that, a lot of that's in partnership with others, where, improving the offerings when we ask about interpreters and all of those things. That I did a lot of listening when I first came and heard about a lot of the challenges that people were having around this. We did idea wave campaigns to get input from various stakeholders. And so a lot of that is listening to what the issues were and building those kind of systems and structures that would help support this. And the question around, so a lot of committee work, it's hiring, it's putting in education, it's building a website, right? It's having access so that people know where to get resources if they need that. Is for us, my team, providing sort of consultative services, because many people face a lot of challenges, like, how do I handle this, or is there something, do you have information on this? So we do a lot of that. So I think I consider all of that infrastructure. And then, is this affected by funding for big has affected by available funding? Luckily, our executive team, and particularly the CEO, Patty Mason, is very supportive of me and the work that my team and department are doing. And so we haven't had any challenges with our funding. We're still fully committed to the work. And I think that that's true across the University of California. Obviously, the things that may change are things that have to change legally, right? And we all know the institution as a whole has been affected by some of the changes, but in terms of the direct work that my team does, no, we haven't.
That's wonderful. Another question that came in is, do these mobile clinics offer services for children in addition to adults?
I think I get this question every time. And so right now we haven't, although I will say our division chief for adolescent health, we're working very closely to start to build those out. So for example, some of the Dr. Janine Young and her team have come to the Haitian Bridge Alliance because they started a new clinic in City Heights with family health centers. And so we are actively working on how do we add in services for kids. And part of the reason we didn't do that is just practically, like, I'm a general internist, so I only take care of adults, but that is our intent. Now, we've done some stuff with schools, but really working to do screenings for the parents who are going to school events. And we want to continue to do that, but we are actively trying to build out services for kids.
That's wonderful. And there's another question. Thank you so much for sharing this project. As a public health alum applying for medical school, what is the best way to get involved as a volunteer?
Yeah. So I think there's probably maybe Laura or at least if someone has put information in the chat, but you'll certainly get my contact information. We have a volunteer form, so you're interested in volunteering. We have a form that you can just complete so that we know, and we can, we'll be able to share where our where the unit is and that kind of thing. So yeah, and I just want to say one thing on just volunteering too. What I'm really hoping is that our mobile health elective will also include pharmacy students and public health students. That was our intention this year. And I think the person on my team who was coordinating that, we didn't even realize, like we actually thought that when the elective goes out, that it kind of is circulated throughout the schools, but that didn't happen this time. But that's okay. But that is our intention, is that we want to see medicine, pharmacy, and public health all working beside each other. We think that the mobile program is a great way to do that. So definitely want to put that out there. And
That
we
is
do in our
wonderful.
team, we have every year I had 3 capstone students last year, and we actually have our list of projects that are going to be going to the to our MPH coordinator for the School of Public Health, because we always have capstone students. I love working with MPH students. So that's another way
That's
to get
wonderful.
involved.
There was another question
Oh,
sent earlier about if you're an undergraduate, how do they get involved? But I assume it would be the same way. Are you accepting undergraduate students for volunteer?
yeah, actually, I was just at an event earlier today, and someone from the Teaching and Learning Commons came up and said, "Hey, can I share this with some of our undergrads?" And so I'm excited about that, because I wasn't sure of the best way to kind of disseminate information for them, but now I have a contact. But yeah, I think so. We obviously the mobile clinic it's small. It's unlike, our fixed sites where there's a lot of space. So we have different events so people can sign up. Not everybody's going to be able to make every one, and we have different roles. And so, yeah, we would love to have undergrads too. And you can just, I can just send me information and I'll connect with the person on our team.
Wonderful. Thank you. Another question. How can existing community health and wellness pop-up clinics run by health sciences schools collaborate with your program?
Yeah, same thing. We're actually doing a collaboration that Dr. Happy Arnetta brought to us, because she does some stuff with the Viet Med, and like that's another event that I think we're doing this weekend, maybe. So just reach out to us. Again, we're very interested in collaborating, and so and again, my philosophy on this is that all of us, many of us, I think anybody who would join this call is interested in advancing health for all, so that all of our populations can benefit. And so I am fully collaborative. We need to work together, right? We're all trying to pursue the same goal, and maybe the way we go about it may be different depending on our areas, but we're all working towards the same goal. And so I think it's better for us to collaborate and think about what piece can I do with mobile, and what piece can someone else do with something else, and how do we collaborate? So I'm very excited to do that.
Okay. And then this is going to be our last question. The map that you showed earlier that shows the different areas of health inequity, do you focus on bringing the mobile clinic to those affected areas or rural areas like the one where you grew up? Do you focus on those areas?
Yeah, so that's a great question. Right now we are saying, we'll go anywhere in San Diego County, but I think the reality is, again, because we're working in partnership, like we're not. This isn't like an extension right now of a primary care clinic. So it's not like we're like, oh, we have the mobile clinic going to X location, on this schedule. So we're really doing it in partnership. And so far, we haven't had, wherever people are asking us to come, if we can go, as long as the mobile unit can fit there, we go, and our driver goes out and assesses the space and makes sure we can fit in the space. But yeah, we work with the regional coordinators for the county to think about different areas. Our goal, what our intention was, is that this mobile health program would serve the individuals and communities who need it most. Those communities like South and Southeast San Diego, where the need is the greatest and people have more access related barriers or challenges. That is the intention. But we also have been doing stuff outside of those areas. So, but that is our intention.
All right. Well, thank you so much. And I know you said it's still version zero point 0.5, so there's going to be more to come and more greatness, but you've already done such incredible work. So thank you for your leadership and for sharing your insights and the impact of this important work. It's been an honor to moderate this webinar with you, for you. To the people who are participating, thank you all for joining us tonight. We really do appreciate your engagement and your continued connection to UC San Diego. Before we close, I'd like to highlight two upcoming alumni events in April. The illustrious Alumni Awards are going to take place in San Francisco on April 16th and in New York on April 29th. So we look forward to welcoming alums and leadership from across our health professional schools at both events. If you're interested, you can get in touch with the School of Medicine at the contact email that they did provide earlier in the chat box. And thank you again for being with us this evening. We hope to see you at our future alumni programs. Hope you all have a great evening. Thank you so much.
Thank you all.